I'm David Haggstrom, and most, if not all of you, already know me. Aaron described some of my institutional affiliations with the Division of General Internal Medicine and Geriatrics with the VA HSR&D Center for Health Services Research Excellence in the Regenstrief Institute. So, like many of us here, I have a complex presence on this campus. Okay, advancing the slide. There we go. So when I was preparing for this talk and thinking about the activities that I wanted to discuss with you, they naturally sorted into a couple of categories. Those included population-based research and patient-centered care. And while I commonly look at these fields of inquiry from the lens of medical and health information technology, whether health information exchange or personal health records, I think that these general fields of research are of interest and a shared agenda among all of us health services researchers. So as a part of this talk, I was also asked to share a little bit about myself. So if you Googled me beforehand, you might have been misled to thinking that I was a mixed martial arts fighter with a 7-3 record from Sweden. So while that's mostly not right, I do wear glasses. And so again, to kind of speak to the moment here, I don't know how some of my stabs of humor here will translate while we do the virtual talk. I may have scripted it in another way, but today you're going to hear me live and unfiltered, and so we will move ahead here. With the well, medical informatics is commonly talked about in terms of the management of health information. I think the conversation quickly and often moves to the discussion of electronic health records. And that's where we begin to tap into the legacy here, where Clem McDonald created the first electronic health record in the country at Eskenazi Health. And so that is really a defining part of the legacy here at the Regenstrief Institute. As the ability to network computers rapidly progressed, hospitals and healthcare systems began to network their electronic health records into systems called Health Information Exchange. And this is another place where the Regenstrief Institute established its international reputation, is the creation of the Indiana Health Information Exchange. So IHI includes more than 18 million patients, more than 51,000 providers, 117 hospitals, more than 18,000 practices. But as I recognize, I am somewhat preaching to the choir here in talking about IHI in these terms. And while we may not all be crazy about HIE, we at least understand and respect the legacy that has been established here at the Regenstrief Institute. And so what I'm going to try to do during the remainder of this talk is like moving from individual electronic health records to health information exchange, move from the individual patient to populations of patients, and try to understand how in health information exchange, what type of populations are served, as well as how we can impact the healthcare received by these populations. So my first entree into this area was when the VA hospital joined IHI. So a little bit of background about myself. So when I first came here, within a couple of years, I gained a VA HSR&D and Robert Wood Johnson Career Development Award for 5 years. And then subsequent to that, I successfully competed for an R01 equivalent VA award intended to evaluate this VA IHI demonstration program. So to do that evaluation, we linked the 69,000 some patients, veterans who are actively being seen at our facility least 2 times in the prior 12 months, and linked those with the many patients in IHI, and achieved a match rate of about 83%. So at least 83% had some element of data in the Indiana Health Information Exchange. We did a project to better understand who enrolled in, what veterans enrolled in the Health Information Exchange. So did this study with Brian Dixon. And what we observed was that patients who were middle-aged or slightly older were more likely to enroll in the Health Information Exchange. Female veterans were more likely to enroll. This may be because they didn't have the same services within the VA as without. There weren't too many racial or ethnic disparities, although American Indians were less likely to enroll. Patients who lived in rural locations of varying sizes were less likely to enroll in the Health Information Exchange. And so something of a disappointment to policymakers, because with the VA's information technology platform, they're very interested in reaching these groups living in rural areas. And then finally, patients with higher Charlson comorbidity index or sicker patients were more likely to enroll in HIE. So if you can't already tell from early in my talk, I am very much interested in how health or medical informatics and health services research can be integrated. I'm interested in breaking down those silos. I'm perhaps not the only person who has noted the convergence between these fields. In an opinion piece in AMIA, Julia Adler-Milstein, who many of you are likely familiar with, comment upon this and how many there's integration in these fields across many journals and conferences. There's the Journal of Healthcare, the Journal of Delivery Science and Innovation, if you're not familiar with, has a very excellent editorial team. There's also some of this convergence in departmental structures, which is a possibility, the Regan Street Institute, how do we better integrate these centers? And finally, in education and training programs. And I'm aware of that the Chris Harley and Nir Menachemi had previously championed a T32 program trying to integrate these fields. And I think continuing to pursue those type of opportunities is important. A couple of comments that Julia made in this article also jumped out to me. One was that informatics work will often attempt to be geared to a health services audience without making clear why it has important implications for cost, quality, or access. So again, highlighting the need for collaboration. She also noted that many studies characterize patients that are and are not using common types of IT, which is ground well covered. So moving on from the prior study, we performed a quasi-experimental design study, which was before and after with controls. And so the intervention group was veterans, as we described, who had enrolled in the Health Information Exchange. There were almost 7,000 veterans. We had a fairly aggressive recruitment approach at the facility, led by a community coordinator who delegated to frontline staff the task of enrolling veterans in the program. And then we compared those veterans to a control group who had not enrolled in HIE. But we had data available from both the VA and IMPC across all of these groups. The outcomes we looked at were fairly traditional health services measures of ambulatory care sensitive hospitalizations, overuse, and costs. We looked at those measures 1 year before and 1 year after a veteran enrolled in HIE. And then we performed propensity score models where we adjusted for sociodemographic and clinical characteristics, like I described previously, to account for the possibility that certain types of veterans were more likely to enroll in the exchange than others. So using the data we had available about laboratory testing, again, inside and outside the VA, we looked at potential overuse. These overuse measures were drawn from a consensus conference that was convened by the New York Health Information Exchange. And so one of the measures that they proposed was looking at CBC and renal tests that were repeated less than 10 days of each other. Looking at the graph or figure on the left, in the blue line, we see the HIE group, which decreased before and after implementation of HIE, while the control group repeat laboratory testing increased, and this difference in differences was significant. Similarly, with liver testing within 6 weeks of each other, in the HIE group, this decreased over time. In the control group, the pattern was flat, and these differences were significant. We also looked at potential overuse of imaging. This is a composite outcome of CT scans, MRIs, PET scans, and nuclear studies. We again saw a pattern where imaging decreased in the HIE group and increased in the control group, although there was only a trend here. And then with ambulatory care sensitive conditions, which is an imperfect measure, but is intended to measure hospitalizations that can be sensitive to high quality ambulatory or primary care, there were not significant differences. What we could conclude here is one of the early positive impacts of HIE may be on inappropriate or redundant testing. And this has been a consistent finding confirmed by a systematic review that Neer and Josh Vest published in the past couple of years. In terms of future strategies to reach the goal of excellence in population-centered research, I would propose these types of studies, considering mixed method implementation studies to better understand the coordination needs of providers that can be addressed by the information in the health information exchange. So much like the Institute of Medicine talked about the quality of care, considering what information at what time needs to be delivered to whom in order to best support providers in their practice. The other type of study that I think we should pursue more of in the future are intervention trials using HIE. And we can look at trials where we enhance existing care delivery with the additional information in the HIE, as well as enhancing HIE with additional care delivery processes. A great example of this is Brian Dixon has participated in a randomized controlled trial with the Bronx VA, where they enrolled veterans and a program where ADT alerts were sent when hospitalizations occurred among a geriatric population, and then a social worker was sent to their home within 30 days of hospitalization to facilitate the transition of care. So considering these type of interventional studies in other populations and healthcare settings, I think is a critical way to move this field forward. So this study gives a sense as the type of research questions or theme that I could envision in our Health Services Research Center in the future, and that is de-implementation. This is a theme that's been common in much of my work, whether it's looking at colorectal cancer surveillance among veterans or at the surgical decisions made by among cancer patients. And this clearly is a topic of great policy importance to multiple stakeholders. There was a recent report published by the Fairbanks School of Public Health addressing factors that affect healthcare costs. This is clearly a multifactorial problem with many solutions that are required, but at least one of the issues stated in the report was that low value care is responsible for much unnecessary spending and is rooted in a clinical and consumer mindset that believes more care is preferred. And one of the solutions proposed here was reducing low value care will require educating physicians and changing the medical culture. So I think in a Health Services Research Center with clinical research expertise such as we have and close ties with the Indiana University School of Medicine, that we're very well positioned to perform this type of work. So to share a little bit more information about myself, what has led me to be interested in these type of questions and why. So I did my internal medicine residency at Dartmouth Hitchcock Medical Center. And this picture is not quite as old as it seems. However, it's not digital, it is emulsion. So, but in any case, that's our residency class. While there, one of my senior mentors was a physician investigator and author named Gil Welch. And some of the books he wrote included titles like, Should I Be Tested for Cancer? Maybe Not, and here's why. Overdiagnosed, Making People Sick in the Pursuit of Health, and Less Medicine, More Health. And so you generally get the idea. And certainly training in this environment has affected my worldview moving forward, that I have a healthy skepticism towards medical care, while recognizing that it can have much benefit, that there is a potential for real and clinical harms. So to make this point conceptually, when people think about the quality of care, they commonly think primarily about the underuse of appropriate services. But if we don't think about overuse, many would estimate that we're missing at least half of the problem. I've gotten this far in the talk without talking about cancer, which may surprise some of you because I am a cancer health services researcher. But this type of issue is important among our populations as well. The use of advanced imaging for patients with cancer has grown rapidly in recent decades. And not only payers, but patients and providers are interested to know the value of this care. So the objective of our study was to understand differences in the rates of utilization of high-cost imaging among cancer patients. To answer this question, we linked the Indiana State Cancer Registry, and this is a population-based registry that covers the whole state of Indiana, intended to capture all of the cases there. And we linked that with the electronic health records in the Indiana Network for Patient Care. Similar to our prior linkage study, we had a fairly respectable match rate of 73%. So in this study, the measures and independent variables we looked at include sociodemographic and clinical characteristics. We also took patients' zip code residence and linked that with community level data obtained from the US Census Bureau to look at community characteristics. I'm aware that there's much work at the Regan Streif Institute looking at social determinants, including in the Opioid Data Commons and the Indiana Network for Patient Health. And again, I think there's an important role for health services research to play in participating and contributing to this type of work. But back to our study, our outcomes of high-cost imaging focused upon CT scans. These are the most highly prevalent type of high-cost imaging relative to these other tests. We looked at the receipt of CT scans within 1 year of cancer diagnosis, and we excluded those who died in the past year. So what we found among the cancer patients we looked at was that among prostate cancer patients, about 16% received a CT scan, and among lung cancer patients, about 50%. So it's fairly inconceivable that about 50% of lung cancer patients received a CT scan. So we were at a crossroads. How do we manage likely incomplete utilization data? So this is a somewhat treacherous part of my talk, but I'm going to try to navigate this passage for you. And how we approach this is what we reconsidered the question. And are there racial differences in high-cost imaging? Where I initially got the idea for adjusting the question this way was at an Academy Health meeting where we were listening to a presentation from a group from Group Health. They were looking at electronic health records in their clinical data warehouse, encountering similar problems in terms of incompleteness of the data. And so at that meeting, they had a biostatistician who made a strong case that in some contexts, absolute utilization rates may not be needed and measures of relative utilization between populations may be of greater interest or importance. So we performed adjusted, zero-inflated negative binomial models, and largely the findings would appeared as we might have expected. Among breast cancer patients of increasing stage, there was more CT scanning. Among patients of increasing age, there was less receipt. They were less likely to receive CT scans, which is a finding we might anticipate. And then among patients who lived in communities with increasing levels of college education, they were more likely to receive CT scans. However, there was an unexpected finding in that African-American patients were more likely to receive CT scans. And based upon what we know about healthcare disparities, this was unanticipated. So we performed a validation step. I read an intriguing New York Times article that described some of this type of work as data wrangling, jockeying, or janitor work. So doesn't sound very glamorous, but is essential to performing this type of research. So what we did is that we did a chart review stratified by patient race, and we compared data we found about CT scans in the HIE data to chart review. So among white patients, there were no significant differences in terms of CT scans in the HIE data or chart review. But among African American patients, in fact, we found more CT scans in the chart review than HIE data. So these findings would suggest, this validation step would suggest that our findings are robust, or even our estimates among African American patients are conservative. So I leave you to think more about what inferences you would draw from this study. But I think two inferences that are worth strong consideration are: one, that this represents true care that's received. And number two, this could potentially represent patterns of missingness that we don't yet fully understand. So, but if we accept the counterintuitive insights from this study, I think there's still important implications, including that although data can potentially guide us to high utilizers, we still need clinical judgment and values about how to use that information. Should we even target potential overuse as opposed to underuse among historically underserved populations? Should we focus upon utilization at all, or rather informed and shared decisions? That's really the outcome we want from the healthcare system. But we don't have shared decisions at a population level. Well, perhaps we could. And then finally, is there a cultural dimension to the shared decision-making process? So returning to a framework for quality of care, we've talked about overuse. So among a population, even if as many as 50% are receiving high quality care, it's critical, I think, as a matter of routine, that we look at vulnerable populations. Otherwise, we might miss unmeasured quality gaps when we consider quality more broadly. I think this highlights another type of question or theme that one could organize a health services research center around in the future. I've done some of this type of work in the past through mentorship. We did a systematic review looking at patient-centered technologies among underserved populations with Will Tarver. And we looked at the association of insurance status with surgical presentation and mortality with Similion Bengiase, who's a breast cancer surgeon. I also developed and co-led with Susan Rawl a study at the Cancer Center where we surveyed 1,000 patients in Indiana. And how we sampled that group is we stratified by race and urban and rural status to better understand patients' health behaviors and health information seeking behavior. Again, to share just a little bit more information about myself. So where I did my clinical research training in general medicine fellowship was at UCSF, or more specifically, San Francisco General Hospital. So that is like Eskenazi Health, a public hospital for that city. And many of the faculty and staff that I worked with there, they wrote the book about medical management of vulnerable and underserved populations. And it was then that I first started pursuing healthcare disparities as a subject of research. Now, at the Regenstrief Institute, we have a reputation for being a source of data, being a rich repository of data. And I've seen this figure in some of your slides before too, outlining that with big data, while the usual suspects, genomic data and clinical data, are of critical importance, that there's many other potential data sources with which we can create a rich tapestry of high value information. So I'd just like to make a couple of comments about how I think we can do that here at the Regenstrief and imagine a future state of our data core. So I think one step to enhancing existing data is understanding that data and performing methodologic studies like I described previously. So we speak about continuous learning health systems. We can think about continuous learning data systems. It's also important to acquire more data to continue to weave and create that tapestry. We have electronic health record data, and that's a strength, and we should build on our strength. We should also pursue fundamental other sources of data that allows us to look at health services like claims data for multiple payers. And I also think linking to more data is a part of the future state we should be working towards. Those of you who work in implementation science are very familiar with interventions now being expected to address multiple levels of the healthcare system, at the hospital level, the provider level, and the patient level. We can also think about multi-level data and the opportunities to obtain hospital data from publicly available resources, provider data, so that we can not only identify when patients are seeing the same provider, but also understand something about that provider, creating derived constructs related to that provider. What is their volume? What is the social network they practice in? The patient level data is still essential, and there's more to be done in terms of collecting patient-reported outcomes across the populations we serve. And in the Health Services Research Program, we have a lot of capacity and expertise to support these type of efforts, including Kurt Krenke, Shelley Johns, and many others. We can also consider very innovative sources of patient data, like social media sensors, or old school approaches like patient surveys. For that Indiana health survey that I described, where we collected data from 1,000 individuals living in Indiana, we also obtained permission from them to look at their electronic health records for the next 10 years. So I went a little quick, but you may wonder why a vacuum cleaner is in this slide now. But this will bring me to my last Clem McDonald anecdote, which I recall people saying that when he was here, he was like a vacuum cleaner, that he'd love to suck up data. So to that end, I think that is a part of the culture that we can build upon, sustain, and enhance to create a hunger for data that'll enable us to answer the important questions we want to pursue. The vision I have in terms of the technical infrastructure in the future, we've spoken about health information exchange. And as it exists, we have the provider who's searching for medical information in the record, entering data into their clinical notes. That provider is communicating with the patient, hopefully in a good relationship, usually is. I think in a future state, we can create our health information networks so that they're more patient-centered, where patients are entering electronic patient-reported outcomes into the electronic health record and the exchange. And then similarly, they're able to pull back their own personal health information and manage and make use of that. I believe there's a very recent policy development where ONC has created greater or easier pathways for patients to do this in mobile applications. So I can only imagine this area will accelerate in the future. Now, there's still a role for a provider. I'm a physician myself, and I recognize that how essential clinical expertise is in guiding and supporting patients. But we, again, perhaps need to reimagine our relationship with information and our patients and approach it in a more collaborative, team-based manner. So in the area of patient-centered technology, the area that I've worked most in is in personal health records, or PHRs. These can be defined as an electronic application through which patients can maintain and manage their health information, or their caregivers can. But I'd point out that personal health records are only one of many patient-centered technologies. There can be mobile apps. One could consider telehealth as a patient-centered technology. And I think what we learn in interventions and studies evaluating one of these can inform our work studying others. So, for example, what we learn regarding pain or stroke telehealth can benefit and inform work with personal health records. Another object of concern in my work has been cancer survivorship care plans. The IOM recommends that each patient receive one of these. They can be simple and as simple as a single document or piece of paper. what is proposed is that this plan should summarize information important to the individual's long-term care, including cancer type, treatments received, and their potential consequences or side effects. The plan should also discuss timing and content of recommended follow-up or surveillance care and preventive practices and how to maintain health and well-being. So our team saw a convergence between personal health records and survivorship care plans and designed a personal cancer toolkit. We did this on the OpenMRS platform, which is an open source electronic health record. And this is one choice among many one could make now, each with its own trade-offs. I've always felt fairly good about the choice that we made here, is because the ethos of open source is one of sharing and collaboration. And I think that aligns fairly well with the research ethos as well. So in the next several screenshots, I'm going to summarize some the main functions of our tool. And those functions are described in the row of green titles in the middle of your slide. So our survivorship care plan provides a treatment summary, which includes information about their cancer-specific treatment, such as surgeries, chemotherapy, and type of radiation. Our tool also provides information about follow-up care. So in the top list, there are guideline recommended follow-up tests that are described. If the patient provides access to the PHR to the provider, then the provider can tailor these based upon the individual's clinical circumstances or needs. And then there's a calendar below that can also enable tracking and planning for the follow-up care tests. The portal has a similar architecture for preventive care, where there's a list of recommended vaccines or screenings, and then below a calendar to plan for those activities. Personal health record and toolkit also provides the ability to create a social network. So here patients can introduce themselves by creating a screen name, providing some brief information about themselves and why they have joined the tool or would like to be introduced to each other. For example, Joe Public states, "Hello, I have an ostomy and I'm interested in connecting with other patients who manage this." So being introduced to anyone in the social network is voluntary for the patient, and also each individual connection is made on a case-by-case basis with the agreement of the patient. Our toolkit also provides a social function and a Facebook-like wall of comments where patients can write entries about their experience with cancer or its treatment. And another part of the architecture of this tool is that survivors can create relationships with providers or caregivers, so family members or friends with whom they wish to share access to the tool. When the patient provides this access, they can choose tiered levels of access. They can provide access to only the medical information in the tool, such as the treatment summary and the follow-up care tests, or only the social information like you're seeing here, or they can grant access to all of those things. And so here again in the comments, patient makes a post and people with whom they've created a relationship can respond in line. There's also a function in our tool to track healthy behaviors. So using standardized instruments, patients can enter information about their physical activity and diet. They can track that behavior over time. And then if they've created a social relationship, those with whom they've created a relationship, the lines of their activity can be traced on the same graphs to provide peer support and comparison. Finally, we have a symptom management function that has a similar reporting and feedback design where patients self-enter information about their symptoms. They can track those over time, and then the tool provides them with feedback and self-management support and tips about how they can manage their symptoms depending upon the level of severity. We've assessed our toolkit with mixed methods. In a qualitative study, we proceeded with the objective of assessing the perceptions of multiple stakeholders of the functions and value of the personal health record. We collected data in use case scenarios where we assessed the usefulness and usability, and also performed semi-structured interviews before and after these use case scenarios to get a sense as to stakeholder preferences. The participants or multiple stakeholders we interviewed included patients who had non-metastatic colorectal cancer, their caregivers or family or friends linked with those patients, and then finally multiple types of providers, whether oncologists, nurses, a gastroenterologist, and primary care physicians. We performed these studies in a human-computer interaction laboratory at the VA, and where we've performed many other usability studies of provider and patient-centered technology, including of the VA's personal health record. So I have very much enjoyed and been gratified by this work, working with human factors engineers. And I think this is the type of work where we're oftentimes most innovative when we collaborate across fields. It takes some work and time to invest in understanding the methods and language of another field. And I'm still not an expert in human factors, but by putting in that investment in understanding the other field, it enables successful and ultimately satisfying collaborations. In terms of the results of our study, from our cancer survivors, we got an overall stamp of approval. They would generally recommend this website to other survivors. The observations that we gathered during the course of the interviews broke down into at least three main categories: comments about the network, or who should be granted access to the personal health record by the patient; information about functions, or were the functions enabled by the personal health record useful activities or not; and finally, insights about implementation, or how best to incorporate the personal health record into workflow and communication. In terms of comments about the network, the bottom line is that patients wanted their providers to communicate across healthcare system and across provider types. And in fact, they believed that they usually were. Perhaps more unexpected or interesting observation was related to patient to provider communication. There was something of a divergence here, where patients and providers both saw the potential for sharing medical information, but patients more often saw potential in the tool for relationship building. So here's some select comments when individuals were describing the journal function. Patients stated things like, it was a tool for reflection about personal thoughts, emotions, and symptoms. It reduced a sense of isolation. Cancer is kind of a lonely illness, said one caregiver. Another patient said it is a way for the provider to better understand the patient's issues. Providers sometimes reflected in a similar way that the tool might allow sympathy and help physicians understand patients holistically. But this was largely a minority view. And more often, providers made comments like the portal or toolkit would make the doctor-patient relationship less professional. Concerns were also expressed about the time burden of sorting through large amounts of unstructured information. And so providers preferred the idea of a review of systems or symptom scales, a pain score, more structured information. Whatever your views of these different perspectives, I think that they're both important to incorporate as we design these types of tools in the future. We also collected some data in a feasibility trial, which I'll briefly describe. We enrolled 30 colorectal cancer survivors at surgery clinics at both IU and the VA. We, in fact, enrolled most of our patients from IU in collaboration with Bruce Robb and his surgery clinic. For the intervention, we enrolled people in the Survivorship Care Plan personal health record, trained them in how to use that, and then sent them home. We then did baseline interviews at the time of that visit and 6-month interviews 6 months later. Our findings were that general self-efficacy was not significantly different at baseline in 6 months. And this is interesting because a lot of the literature around personal health records suggests that these tools might promote self-efficacy or engagement. General knowledge was also not significantly different baseline in 6 months in our pre-post study design. Now, knowledge has a looser association with behavior, so it's less unexpected. And then finally, the surveillance testing, guideline concordance surveillance testing increased at baseline in 6 months. And this was the primary target of our intervention, and so an encouraging finding. So I've described my work with, and my team's work with OpenMRS and our evaluation of a single technology platform, but what about others? So I think to reach the goal of excellence in patient-centered care and technology research, we should consider developing or providing investigators with ways to support work on platforms based upon their questions and goals. OpenMRS is certainly a viable platform that others have used. Actually have a trainee postdoctoral fellow in a T32 program who's building his proposal upon our toolkit. But one can consider other platforms as well, including with our major healthcare system partners like Eskenazi and IU Health and their patient portals such as MyChart. Lifomics is also a major presence in our academic setting, and they have a mobile applications and is another possibility to consider, in addition to designing new apps altogether. But I think we can create an ecosystem depending on an investigator's goals and questions. Another strategy we could take towards moving towards the goal of excellence in patient-centered care would be serving as consultants for entrepreneurs who'd like to test new health information technology in a healthcare setting. Now, as I was saying in a conversation earlier, I do not have a lot of experience necessarily in this type of engagement. However, I'm confident that I could advocate for investigators in building these type of relationships and highlight the deep and outstanding clinical and research expertise we would bring to the table and be vital partners in such relationships. I think there's also many opportunities in implementation science in this area. Again, partnering with healthcare organizations, we can facilitate the development of new functions in existing portals. Looking at the existing IU Health or Eskenazi portal, there's nothing like the functionality that I previously described in their portal, but I think there's clear patient needs. So as we develop those new functions, we can assess them with robust implementation study designs, including hybrid implementation trials, with which I have a lot of experience with, but we can tailor the study design to the healthcare and study context. Advantages of this approach include greater impact and reach. So we would potentially reach more than the patients in a single study, but be able to reach the large populations that the healthcare systems we work with serve. Another advantage would be a greater likelihood of engaging providers. If leadership is engaged and supportive with our initiatives, I think that's more likely to create incentives where providers would do the same. And finally, it's a more pragmatic study design and results in greater external validity. I'd like to make one final point about data, circling back here some, and that these patient-centered technologies create a great opportunity to collect patient-reported outcomes data among large populations. Now, this can be patient-reported outcome data drawn from the unstructured data in the EHR using our expertise in natural language processing. I think it's also important to accompany that strategy with structured electronic patient-reported outcome measures that have been validated to better understand, track, and meet our patients' care needs. So towards the end here, I'm going to pose a mildly provocative question. And this is intended for dialogue as much as anything. But what should be the name of our center in the future? Currently, it's the Center for Health Services Research. What's the definition? Examining how people get access to healthcare, how much care costs, and what happens to patients as a result of this care. The main goals of health services research are to identify the most effective ways to organize, manage, finance, and deliver high-quality care, reduce medical errors, and improve patient safety. So this is a pretty broad definition, fairly interdisciplinary, so I think it fits our work. But how about try on for size a different definition or name, the Center for Healthcare Delivery Science. how healthcare delivery science is defined as focusing on ways to improve health and healthcare services provided to individuals and populations. Now, this definition obviously conveniently aligns with the structure I've outlined in my talk, but I believe has much more to speak for it. One, it could highlight the excellence in clinical research that exists in the center, as well as our strong relationships that we have and can build with our healthcare system partners in the School of Medicine. I also think in terms of nomenclature that this is somewhat, at least in my observation, where the field is heading, that the major annual meeting of health services research is called Academy Health. Most schools of public health no longer have departments of health services research, to my knowledge, but have moved to health policy and management. And finally, at the NIH, or at least the NCI, where I was previously, the Health Services and Economics Research Branch has changed to the Healthcare Delivery Research Program. So again, this is a modest proposal for future dialogue. I don't want to create a collaborant situation for those of you who may remember that. Guiding values that I would propose for the center in the future, regardless of who the leadership is, would be the following. Pursuing equity as a guiding value. How can we best meet the health needs of vulnerable populations? This also would apply to our workforce. How do we promote diversity among our faculty and staff? Second, stewardship. How can we make wise use of resources? How can we do no harm? And again, I think this applies to our work environment as well. I feel very fortunate to work in a school of medicine and at an institute where I'm able to pursue questions that matter to me and have the potential to help people. As we do that, I think we need to consider carefully, given this unique opportunity and these resources, how can we be the best stewards of those? And then I think excellence should be another guiding value, always striving for high quality scholarship, and that being the standard that we hold one another to. And I think this somewhat leads to the final, perhaps most important value outlined here, trust. What can we do to strengthen the bonds of trust between patients and providers? We alluded to some of that with the personal health record work and the patient's yearning for a relationship. Among communities and hospitals, with Sarah Weefe's interim directorship, I think we've already learned a great amount about community engagement and can learn more about how we can do that in partnership with the CTSI. Deb Blitzelman also has led work in that area. So how do we strengthen those bonds of trust? And then importantly, how do we strengthen trust among ourselves? We're a very interdisciplinary research center. So how do we create trust in teams and move so that we can move forward with confidence into the future? So I want to thank my family, who is a constant source of support and inspiration. And I'd like to thank you for your time and see if you have any questions or ideas in the time that remains.
Hey, David, this is Peter. Can you hear me?
Yes.
Hey, wonderful talk. Thank you for that. And really wonderful thoughts there at the end. Really like the provocative proposal you ended with. Can you say a little bit more? I'm just going to be nitpicky here just because you asked for it. So with the idea of healthcare delivery science, which I really appreciate, what are your thoughts about more broadly health and healthcare and sort of the distinction there? Because you sort of say that in the definition, but I think you've made a very strong case that already a lot of our work focuses more broadly on health beyond the traditional healthcare environment, and also that we have opportunities to extend further into the larger health space and probably an obligation to do so. So I just wondered if you would riff on that a little bit.
Yeah, well, you raise a great point. I recognize that in terms of overall health, that the healthcare delivery system may be responsible for a relatively low proportion of the outcome of overall health. That said, I do think that, as I alluded to in some of the concluding comments, that organizations are starting to change that have traditionally been very service intensive, like hospitals, and thinking about not only how do I serve the population that walks in my door, but how do I serve the needs of the community. Eskenazi has perhaps been a leader in that area. So, I think healthcare delivery systems can reach back out. I also believe that, as a general internist and someone who practices primary care, this feels, very intuitive to me. Of course, we manage chronic disease and acute problems, but, a huge part of our work is promoting health and well-being. It's not only primary care's responsibility and role to do that, perhaps do that more broadly across healthcare providers of all types, but that's clearly a part of what we do. So, again, a modest proposal, but the idea of healthcare delivery science, I think, may reflect more, where we sit in the environment, like who are our, most vital and strongest partners. And that's worth further discussion, the School of Medicine, healthcare system partners. Many of those relationships are old and being sustained, but, I think having a name that speaks not only inside our institution, but outside our institutions, so that, if the nomenclature is shifting this direction, people can say, aha, like, I understand what that is. That's what they name it in the world I'm familiar with. I just want to highlight those partnerships and stay abreast of changing language.
Thank you.
Hey, David, this is Titus. I have another question for you.
Yes.
A somewhat more provocative one. Given the tenor of your talk, why not merge the Center for Biomedical Informatics and the Center for Health Services Research, and then come up with another new name? Or maybe use the one you suggested.
So I think what I heard is, why not merge the centers?
That is.
I think that, I'm relatively, I've been a part of the organizational chart for years, and I'm early forays thinking about how it may appear. As you can see in my talk, I'm strongly interested, some based upon my own work, but some based upon opportunities and how I've seen the health services research field evolve to considering, greater opportunities and mechanisms for integration and collaboration between CBMI and health services research. That said, I still think there are some parts of the health services research tradition, whether in analytic models, study designs, and implementation science is a hugely important part of the field in my view, and certainly a strength here at our BA, that I think there's still unique areas of strength, but I think thinking how they can be complementary and greater collaboration would strengthen us all.
You've been practicing for the Democratic primary debates.
I know, it's like playing basketball. I'm headed for March Madness in an empty stadium.
We probably have time for one more question, if anyone has one.
David, this is Kurt. Can you hear me, Kurt?
Yes.
Yeah, just one question. You've been here long enough, so we kind of have two centers of health services, one here at Regenstrief and one at the VA. And, a longstanding conversation is how to get more collaboration between those two. I know the incentives for each system are differentially aligned, but would you have any thoughts about over the next 5 to 10 years, how to do better in terms of bringing those two areas together? You've lived on both sides, I've lived on both sides, others have as well.
Yeah, well, I think that, the VA Research Center is, I'm a part of it and will continue to be in the future. And I think that it's a strength for us to build in. build upon. It's a center within a center. And I think that in the future, and I'll be interested to learn more about others who face this challenge, but greater growth in the Center for Health Services Research, or whatever we call it in the future, that where people have more of their time dedicated to their alone, is important to create a critical mass of activity. But at the same time, I think that arrangements whereby whereby faculty at the VA and perhaps vice versa can more seamlessly move between the two environments would strengthen both. It would, you know, allow investigators more potential professional fulfillment to provide unique opportunities outside the VA, and it would, you know, also benefit the Regan Street Center for Health Services Research to draw upon that expertise to, and also to even in recruitment. If people say we were to recruit an implementation scientist who wanted a stronger, more predominant university presence, I think the existence of people at the VA is going to be very attractive to that person. So I think creating the opportunities for investigators to more seamlessly move back and forth, and for the sake of professional fulfillment, but creating a greater critical mass at the Regan Street will be important too for long-term success.
Okay, for all of us, David, thank you so much for this fantastic talk, and of course for your flexibility in all of this. I'm sure there'll be many more questions to follow, and we hope you enjoy the rest of the day. And thank you everyone who joined us in participating in this talk, and thank you for all your flexibility as well.
Thanks, Aaron.